Treat That Pain is a series of brief presentations on the essentials of managing cancer pain, with special emphasis on safe and rational use of narcotic medications. It's an initiative of the National Cancer Grid India. Every attempt has been made to keep the contents evidence-based. Opioids are the gold standard analgesics recommended by the World Health Organization through its analgesic ladder for treating moderate to severe pain which are not responding to non-opioid analgesic therapy. It also recommends it through the WHO model list of essential medicines. Evidence-based recommendations from international bodies include use of opioid analgesics in treating cancer pain. Under-treatment of severe cancer pain is a reality, especially so in India. There are several contributors to this unfortunate situation, and this presentation will elaborate more on the prescriber concerns, along with suggestions and approaches to improving safe and rational medical use of opioids. Physicians' reluctance to administer opioids has been identified as a barrier to cancer pain management. Prescriber concerns with opioid therapy fall under three main categories. The physician may worry about the addiction potential of opioids and choose to reserve its use for later when patient is in terminal stages. They may restrict use to small infrequent doses for fear of overdosing and hastening death. Or concerns about debilitating adverse effects such as drowsiness, confusion, delirium may lead to avoiding its use in patients who are sick, elderly, very young, or fully functional, which means literally most patients. For this presentation, let's focus particularly on the addiction potential of using opioids for treating cancer pain. Let's try to understand the doctor's dilemma a little more clearly. On the one hand, relieving pain is an ethical obligation as suffering due to pain is highly prevalent in cancer patients and relieving it improves the treatment adherence and the quality of life. On the other hand, there are unresolved concerns about non-medical use, misuse of the opioids, and even sometimes the dose that may be used and for the duration that it may be used for. The undergraduate and postgraduate training has not provided adequate clarity on using opioids, especially long-term, as required in cancer patients. Reports on opioid crisis from high-income countries have added further cause for concerns to this dilemma. The action of opioids is primarily through mu receptors which are present extensively across the central nervous system. Opioids acting on mu receptors on the nociceptive pathway relieves the pain quickly. There is also a slow component that contributes to the tolerance and the occasional hyperalgesia seen with long-term opioid therapy. Opioid stimulation on the mu receptors in the limbic system results in fast release of neurotransmitters including dopamine, some peptides, and serotonin, endogenous opioids that cause reward and pleasure experiences. When this effect wears off, the anti-reward pathways get activated and release the neurotransmitters such as corticotropin releasing factor, noradrenaline, dynorphin, and orexin, which leads to dysphoria and distress. In some patients, probably genetically predisposed, have high concentration of mu receptors in limbic system, and the experiences mentioned above are particularly intense, and these are the very patients who develop substance abuse disorder. With continued use of opioids, the release of reward neurotransmitters decrease and the release of transmitters in amygdala associated with dysphoria and stress increase. This state triggers aberrant behavior in individuals who have had intense experiences due to higher concentration of mu receptors in their limbic system. They seek higher and higher doses to increasingly recruit new opioid receptors and seek to cause either positive reinforcement, that is, to increase the intake and restore the intensely pleasant experience, or The negative reinforcement, that is, increasing the intake to avoid intensely negative experience and restore the state of normalcy. Non-medical opioid use may be considered as a confluence of several conditions involving the person and the specific agent. Opioids working through the mu receptors, especially in the ventral tegmental area, trigger reward experiences. And through its impact on the inhibitory excitatory neurotransmitters, they disturb the natural balance between the anxiolytic system and the stress system. These effects alone cannot account for the variances between individuals in terms of non-medical use behavior. It is common knowledge that many individuals at some point in life try drugs known to have abuse potential without succumbing to dependence or abuse. Some use it just once and get hooked. There are individual and individual situational factors that also seem to play a major role. Research reveals that genetic predisposition to non-medical use behavior is seen in those who have increased density as well as increased expression of the mu receptors. Factors that contribute to changes in the individual development, the environment in which people grow, the socio-economic background, the familial and community behaviors, disorders of mood, history of abuse or trauma, and stress responses all seem to have an effect and contribute to the non-medical opioid use. This word cloud lists what are termed as aberrant behaviors, or more aptly called as non-medical opioid use behaviors. There are several behaviors listed here. For example, unscheduled appointments, self-escalation of drugs, reports of lost or stolen prescriptions, doctor shopping, hoarding of medications, increased anxiety or insomnia, impaired functioning, or injecting oral formulations. Obviously, some of these behaviors, like injecting oral formulation, is much more worrisome of possibility of substance use disorder. Whereas a patient coming with an unscheduled appointments for a medical opioid refill may simply be doing it because the cancer has progressed and the pain has increased and the current dose may not adequately take care of the existing pain. The risk for non-medical use is greater in patients who are younger and male. The highest risk is probably in the teenage group. Those who are greater than 45 years and of female gender carry a much lower risk. Personal or family history of tobacco, alcohol use, personal or family history of mental ill health, depression, or substance use disorder amplify the risk for non-medical use. People with economic insecurities, unemployed, or those with lower income also carry a greater risk for non-medical opioid use. The opioid risk tool was developed for assessing the risk of aberrant behavior when treating non-cancer pain with opioids. The individual related risk factors mentioned earlier are scored and the overall risk is stratified depending on the total score. This tool has been applied and used for predicting the risk of non-medical opioid use when treating cancer pain as well. CAGE-8 is a modified version of the cut-down, annoyed, guilty, and eye-opener, the CAGE tool, applicable to assess alcohol use behavior and to assess the non-medical drug use as well. It has a sensitivity of 88% and a specificity of 55%. The risk for non-medical opioid use is higher if the patient gives one or more positive responses to the questions listed in this tool. Dr. Witzthum and colleagues studied persistent opioid use behavior in a cohort of more than 106,000 cancer patients over a period of 15 years to identify risk factors associated with adverse opioid-related outcomes. They observed that 8.3% of patients exhibited persistent post-cancer treatment opioid use, and 90% of this group had history of substance use prior to oncology-related opioid treatment. Further, the study noted that the rate of opioid abuse and dependence was 2.9%, and the rate of opioid-related admissions due to complications and toxicity of opioids was 2.1%. This study, done by the National Cancer Institute, represents one of the largest comprehensive evaluation of persistent opioid use and non-medical use in cancer survivors, and the first to construct a predictive model specific to oncology patients. The output of the study is accessible as an online opioid risk assessment tool for cancer patients on this website, canceropioidrisk.org. This India-based study, published in The Lancet in 2001, followed up 1,723 patients receiving tablet morphine for cancer pain relief under home care services. It found no instances of opioid misuse or diversion, and the instances where there was increasing morphine requirement was found to be in proportion to the progression of the cancer and the pain. The research team concluded that the processes activated for maintaining the accountability for morphine stock, the prescriptions, diligent documentation of dispensed drugs, and regular review of patients incorporating pill counts supported the safe use of this essential drug. This map is sourced from the International Narcotics Control Board and the WHO Global Health Estimates of 2015 and represents the distribution of opioids amongst different regions across the globe. Several high-income countries from North America, Europe, Australia, and New Zealand, with less than 20% of the world's population, use more than 90% of global morphine. Hey, where is India? We need a lens to spot India on this map. The increased morbidity and deaths due to prescription opioids in the United States was a result of altered standards and mandates that triggered extensive use of opioids and increased opioid prescription by primary care physicians to meet pain management benchmarks for all, even those with chronic non-cancer pain. Well, the opioid crisis in the United States of America and the very poor access to cancer pain relief in India are two opposite ends of the prescription spectrum. It is to be noted that in India, more than 96% of cancer patients in pain have no access to opioid analgesics. This 2018 study, published in the Journal of Clinical Oncology, analyzed opioid-associated deaths in patients with cancer over a 10-year period of the opioid epidemic in the United States. The study concluded that death from opioids as the primary cause noted on the death certificates were 10 times less likely to occur in cancer patients versus the general population. Also, the cancer patients who died due to opioid use were different from those who died due to opioids in general population with higher educational, stronger socio-economic background. They were also much older. Now, let's summarize our discussions and approach the doctor's dilemma with a fresh perspective. We are aware that pain is one of the most frequent and feared symptoms in patients with cancer. It would indeed be unethical to not prescribe opioids when indicated for our patients. We are also aware that aberrant opioid behaviors are possible, and such behaviors indicate a risk. Their presence do not diagnose substance use disorder in our cancer patients. When a patient does exhibit aberrant behavior, we need to make an attempt to understand the motivation behind it. Do they reflect the desire to ensure that pain gets relieved? Is it because it's undertreated as of now? Or are they hoarding? Is that done to avoid future pain and medication costs? Or is it to get high? which indicates psychological dependence and possibility of substance use disorder. The Luke Hansen study mentioned below on HIV patients using opioids for pain management suggests that even amongst patients with known substance use disorder, aberrant opioid behaviors are common but not universal. Opioid deaths due to misuse and overdose were 10 times less likely to occur in patients with cancer compared to those patients where opioids were used in non-cancer situations. So, we may surmise that when treating cancer pain with opioids, it's important to maintain a balanced attention on relieving the pain and on prescribing practices through universal precautions, and this can prevent non-medical opioid use. Details of safe and rational opioid therapy with both the universal precautions as well as the enhanced monitoring required in specific situations is available as a separate presentation in this series. We list the universal precautions for safe and rational use in this table, and you may choose to pause the video right now and go through the steps of prescribing practices when using medical opioids to treat cancer pain.